And we will start now the WFNS Education Symposium number 13. It is on endoscopic spine surgery, and we will try to answer the question, is it the new standard? I call Dr. Hyun-Sung Kim, he's with us, to moderate the session. I think Benedict did not join us yet.
Okay, hi everyone. I'm Hyun-Sung Harrison Kim from South Korea. This session is a WFNS Education Symposium 13, and the title is the Endoscopic Spine Surgery. Is it the new standard? And we have a full lecture program of the endoscopy with the tube Jayesh Sardhara, and the posture with the water irrigation system by Jose Lame Guerra, and endoscopy fusion by me, and the final future of spine endoscopy by Benedict Bukrahart. And now we will start the first lecture from Jayesh Sardhara for endoscopy with the tube. Jayesh?
Yes, yes. So thank you, Dr. Kim, for the I would like to thanks WFNS committee, Dr. Zeli sir. Thank you for this opportunity. Good evening, Dr. Mana sir. Uh, so I'm going to share the screen.
Please share your screen, yes.
Am I visible? Yeah, my screen is visible.
Yes, we can see your screen.
Okay. So, okay. So my topic is endoscopy with the tube. Just a second. Yeah. So in this, just a second, something. Hang just a second. Again, I sharing stop. Sharing the screen. Stop. My screen is not visible, right?
We can see your screen, but we can, okay, your screen disappear.
Just give me 1 second. Okay, so here it is. So my topic is endoscopy with tube. And in this 21st century, it is an era of minimalism. And the world is trending from open spine surgery towards endoscopic spine surgery. And of course, we all know that there are a lot of advantage with because of open surgery to minimal invasive spine surgery. I believe that the spine endoscopy should start with lumbar L45 or L5S1 disc, mainly towards the left side. We should choose a lean and thin patient. Lot of advantage for that. Gradually, after 30-40 cases, we should move towards the next step, that is a canal stenosis as well as lumbar fusion. And after we more become confident in the spine endoscopy and three-dimensional anatomy of the spine, then we should at the end move to the cervical PIVD and stenosis at the end of the curve. This fantastic system, this tube is called Destando tube, and it's developed by Jean Destando. I do all the spine procedures with this. So this is the system, and there are three tubes in this instrument. One is obturator, the outer cannula, and this is the inner cannula. So it's almost 1.8 centimeter tube. It's require almost 1 centimeter to 1.2 centimeter in this. Now this inner cannula has four channel. One is for success, this working channel. This small one is for this for now hook, and we can call this now retractor. There is a 4 millimeter endoscope channel. Normal 4 millimeter 0 degree endoscope is being used for a Destando. That is the most important part. We doesn't require a new endoscopy system to buy, more economical. Fourth channel is for suction. Any normal available suction can be used. And so this is the system. Position. Usually there are two kind of position. I do all the endoscopic discectomy in the lumbar flexion. So either you open the Wilson frame, it open the interlaminar and foraminal space and need less and less bony decompression. This is the advantage. So this position is required for endoscopic discectomy. Another position, which is lumbar lordosis. So I do all the canal stenosis, decompression, and fusion and fixation in normal natural lumbar lordotic position, because it facilitates the decompression as well as fixation in its narrowest dimension. So patient have a maximum advantage of that. So the incision is more standard, just 1 centimeter lateral to the spinous process. Our tube should be exactly targeting the upper lamina. Suppose I am going for L4-5 discectomy, I am supposed to target on L4 lamina and L4 spinous process while docking and marking. The marking is very important. So this is first step is you go subperiosteal to the spinous procession after incision. You dock this obturator and outer cannula exactly over the L4 lamina. And I use two cotton patty, that is we call it peanut, one at the upper edge of the lamina and the other one at the lateral to the facet, so facet joint. So these two peanut or goes piece prevent the, because this is the advantage of Descendant system is highly mobile system. That is advantage also, but the disadvantage is muscle can be popped out. So by this method, I can avoid all muscle creeping and popping inside my endoscopy field, and the view will be very, very clear. So after I dock the tube, this is the endoscopy picture. This is a 46-year male and who has a right side radiculopathy and there is a EHL weakness. So I'm doing L4-5 endoscopic discectomy. So the docking, you should start with the L4 level. So here is the L4 lamina and the 6 o'clock is the facet. So the standard lower half of upper lamina should be drilled till we reach the ligament of flavum insertion, then ligament of flavum being removed, and 10 to 20% undercutting of facet is required for drilling. You can see there how much drilling is only just a few millimeter of upper lamina supposed to be drilled. And we expose the dura, the ligament of flavum supposed to be carefully excised through punch. Now the lateral limit of dissection or facet drilling is you're supposed to see the lateral edge of nerve root. Here is the L5, right L5 nerve root. It should be very, very clean picture and the lateral edge supposed to be seen free without any retraction. Now I use two cotton patty, one exactly here at the shoulder. In the shoulder of the nerve root, I push beneath the lamina so that there are two advantages. One, we can retract the nerve root. Second thing, it's also prevent a soiling of blood and your field should be very clear. So this will help. It's also control the epidural bleeding. So two cotton I use. One is above shoulder and one is at the axilla. And here I am retracting the nerve root, and there are another instruments called nerve retractor which we can place. We can see that this system is very mobile. So exactly where whatever the angle you want to work, you can work and you can decompress all the four corners of that spine. So this is retracting nerve root. This is the disc prolapse exactly at L4-5. Now I'm going to coagulate it. There's a bipolar used for decompression, and you can see that I am using the all normal instruments we are using for other normal surgery. So after discectomy, all the high pressure disc degenerative part is coming outside, and that part is excised. So we can see not only the ipsilateral root, but even in fact the contralateral root is also get free. So we can see the endpoint is very, very clear from starting from shoulder to axilla. So another patient with 35 lady here, I want to say it's a pre-op image. She has a right side S1 radiculopathy and post-op hemorrhage is very clean. And so after annulotomy, we can see all the extruded part. Only I remove only the extruded and degenerated part of the disc. Other annulus I always coagulated. Now for canal stenosis, it's very, very important. It's a 52-year lady, 52-year female, and have a neurogenic claudication and sitting up only 100 meters. You can see there is a severe canal stenosis. It's also important. while you remove the hypertrophic ligament of phleum, not only the dura, if you drill the base of the spinous process, and you can also get the entry to the opposite contralateral superior faces, and you can decompress the contralateral nerve root going into the foramen very well. You can see the contralateral nerve root in the foramen. You can see the ipsilateral nerve root in the going into the foramen. These are the two important point and place where you decompression is important. Otherwise, there will be a residual stenosis. So this can be possible by a single small incision, contralateral, just base of spinous process supposed to be drilled. Now, most common complication of the endoscopy with the tube or other minimal invasive spine surgery at the lumbar level is a CSF leak, and commonly happen while you are removing the chronic ligamentum fleum hypertrophy, particularly while separating from the dura. Without separating the dura, there will be a leak like that. So my principle is very clear. If there is only arachnoid prolapse, I do nothing. If there is a nerve prolapse and there is a gross ESF leak, usually I keep it inside by some dissector, and I use artificial dural page. Very occasionally, rarely it requires suturing, but it's absolutely fine. Like this kind of artificial page is required. Now, few slides for cervical spine endoscopy. So out of all the options available for the cervical PIVT surgical option, I'm telling the conventional treatment of fusion surgery, and the now world is trending toward the motion preservation surgery. So if you compare the CDF and artificial disc replacement, if you have option of posterior approach like posterior cervical discectomy and foraminotomy, this is the fantastic because it doesn't require any instrumentation, preserve the motion of the cervical spine, which is very, very important. Anterior indication of cervical spine endoscopy, which can be do with the tube also, is the SCDF and artificial disc replacement. Posterior approach, the indication are the young patient unilateral, soft or hard disc, which is compressing the one side of nerve root like this at C45 and C5, C6 prolapse. This require endoscopic lamina foraminotomy. You can also operate a multiple level of compression, compressive cervical myelopathy at 2 or 3 level by the single incision by posterior where it is indicated. And you can also approach a cervical IDM, small size on one side in the young patient. This is indicated by endoscopy. Now, very, very important point. If you are doing the posterior endoscopic of cervical approach, where do you dock the tube? So your tube is docked exactly at the V point. So where is the V point? So the adjacent lamina, superior lamina, this is the inferior lamina, where it is meet at the apex. This is the facet joint, and this is called V, where exactly you're supposed to dock the tube. Now, idea of lamina foraminotomy is you convert this V into U. So you for that you require upper and lower half of laminotomy and 20% of 10 to 20% of facet joint. So this require for one level decompression. For two level decompression, you require one full lamina and upper or lower half of half lamina for two level decompression. For three level decompression, you require a one full lamina and adjacent upper and lower half lamina through only a single incision. Now, what is the difference between a lumbar and cervical spine endoscopy? It's a very important point. While you are doing a cervical spine endoscopy, the nerve root lies in the lower one-third of foramen, unlike the lumbar spine, which is the upper one-third of foramen. It means that while you are decompressing, the nerve root is not going away from you, rather nerve root will come towards the you. So this is very important that you know you are decompressing the nerve root which is coming toward to you, that you need to decompress. The other part is the vertebral artery. The dam, it is lying just at the entry point, targeting point, that is the lamina facet joint. So you have to work medial, medial, and medial. Other important landmark point is up to C4. You can see that all the V points overlies the nerve root crossing. It is very easy to find the nerve root. But at the C5, C6, and C level, because nerve root overlies, dura, and more course will be oblique. So V point will going far away. You may require more variable facet joint drilling, sometimes 10%, sometimes 20%. But remember that 50% of facet joint on one side, other side can be drilled without, you don't require stabilization for that. So the posterior approach, the incision would be 1 centimeter lateral, exactly at the level, exactly at the lamino facet point. And you have to do some little bit neck flexion, so they open the foramina. This is the tube used, then you put an incision subperiosteally, you apply this obturator and outer cannula, you look at the CM, you confirm it, and after you enter the scope, this is for single level C5, C6, right side for aminotomy and discectomy. So here is the V point. This is cranial C5 lamina, C6 lamina, and this is a facet joint. And we can see here, this V supposed to be make it U by drilling the upper and lower half of lamina, and facet supposed to be drilled, the ligamentum flavum should be excised. Now, few things is important in the while you are operating the cervical spine. One, there will be a bleeding which is more. It can be controlled by only gel form or something or flow seal or surgery flow. Second thing, that now supposed to be, you cannot retract the cervical cord or thecal set like in the lumbar spine. This is the disc, the soft disc which is compressing the junction of the V point. You can excise here. Now, an idea is not to just a discectomy, but idea is to decompress the nerve root at 360 degree. For that, you have to decompress superior, inferior to the nerve root. Beneath the nerve root, you have to drill. If there may be any osteophytes or soft disc, you have to remove like this. So here, the osteophyte has been removed, and the lateral margin, the nerve should be very freely pulsatile like this for one level. Like this patient, it's a 28-year male with this disc prolapse C5, C6, and we can see the lateral limit of disc, the decompression is that it should be the lateral edge of foramina exiting, this nerve root exiting point. So you have to drill like you are undercutting of the facet joint, and it should be 360-degree free. You can palpate, you can feel the freeness by dissector putting inside. So this is the end point of the laminoforaminectomy. Sometimes I started for 2-level cervical discectomy. This is a patient with severe right side radicular pain, C4, 5, and C5, C6 foraminostenosis. If you want to do a decompression by a single level, you can leave this kind of island lamina, and you can decompress both the level through a single incision. And you can do a 2-level foraminectomy to a single incision. For multiple level decompression, so this patient was priorly fixed with the anterior cervical fusion and 2-level, there was compression, so I decided to go from back because it is already fused anteriorly. For that, you have to dock exactly over the lamina, but not in the V point. And then you drill the lamina gradually. Full lamina is supposed to be decompressed. Look at the mobility of the cervical spine. In the single level, you can decompress up to 3 levels. And the bleeding is very common problem in the cervical spine. For that, you need to I just put a gel foam beneath the lamina, and it make my walk. Sometimes I also require a flow seal or surgery flow for that. Yeah. So like a lumbar vertebra, lumbar spine endoscopy, the base of the spine is supposed to be drilled, and it will good enough that you can also decompress the opposite side also like lumbar spine, like same. So this is the completion of 2-level lumbar decompression. The patient with a 3-level compression, the single incision, it also helps to decompress at the 3-level. You can see here, this is the incision. So 3-level also can be decompressed with a single incision. Okay, so you can see the level of bony decompression, 1 level, 2 level, and 3 level. So midline spinous process is intact, your facet joint is intact, so it is obviously stable, so it doesn't require any instrumentation. The literature says that the anterior and posterior approach, the discectomy and ACDF have the same clinical response. And 5-year follow-up, even you can decompress cervical lordosis less than 10 degree, and 5-year follow-up says there is no progressive kyphosis even after 5 years. Because you are using endoscope, the only facet drilling is required is 10% compared to 30% with other procedures. Other indication is IDM. The single level IDM can be easily decompressed with this kind of tube. So at the nutshell at the end, the endoscopic discectomy and decompress is one of the good alternatives with equal clinical outcome and better edge in motion preservation in patient with a single or multiple level cervical disc condition, canal stenosis, in which posterior approach is indicated. because with a single level, you can decompress it at 3 level. At the end, for all the spine endoscopy or miss, please remember that incision doesn't make it miss neither tube. Rather, if you don't have anatomy knowledge, it may make you a miss because it's all the radiology. It's a technology dependent. So understanding of the 3D anatomy, the preservation of bony and soft tissue anatomy, and meticulous dissection hemostasis is the key for the spine endoscopy. Thank you so much for your attention.
Thank you so much, Dr. Jayesh. And there still have no question. Maybe if you have any question, please please writing on the message to here. And I have a question that maybe your your technique may be some different with the some tube conventional tube technique. Maybe what is some different compared to the conventional tube technique? And the second question is that your technique is air-based technique. Currently, we use the mainly some water-based technique. What is some difference is that?
Very nice question, Dr. King. So the conventional tube, like EasyGo system, is also good. The difference between the EasyGo tube and this the standard tube is that this is the mobile, no need to fix, and that mobility we can use. That we can after once we become more acquainted with all the cases like cervical lumbar, so we can decompress at every corner of the lumbar and cervical spine at the level of 4 corner. Like we can decompress contralateral side, ipsilateral side, all the foramina because the mobile. Second advantage is with the single incision we can decompress at the 3 level, which also of course can be decompressed at the other level. This is just a tube, more economical also, and you will say it's a air-based system, not a water-based system. So while you are learning, you are in a learning curve. The most important advantage, what I feel, the learning curve is relatively easy while you are starting the procedure. You should start with this kind of tube because all spine surgeon, neurosurgeon are more familiar with the microscope and two-hand surgery with the 2 hand. With the water-based system, with the single hand, the learning curve is little bit tight and more long. So relatively, this is the difference I feel.
Okay, thank you so much. Your great lecture.